Is human plus AI or AI alone better at making decisions? And so, for example, making the right diagnosis from a simulated patient case. Human plus AI or AI alone? And the answer is AI alone. It's paradigm shifting, it's frustrating, it provokes anger and resistance, and of course, medicine is not just diagnosing things. We all know that. But it does make you think. Our worry and resistance about adopting AI, as well-intentioned as they are we actually harming patients if we are inferior to the new tools that we are developing? It's very thought-provoking.
I'm Lisa Rosenbaum, host of Not Otherwise Specified from the New England Journal of Medicine. And that's Steven Lin. He's a family medicine physician and chief of general primary care at Stanford University. He also founded the Stanford Healthcare AI Applied Research Team, much more easily referred to as HEART. I think he's the perfect person to talk to us today about the role of artificial intelligence in primary care. But before we get into it, I'll just say I've put a lot of energy into avoiding AI. People ask me all the time why I haven't covered it, given how much it's likely to transform medicine. And the simple answer is that I'm just not a technology person. I really feel like I can barely use an iPhone, at least not in the way that other people seem to. And when I manage to do something like set up a printer, I often think to myself, this may be my life's greatest accomplishment. My sister's basically a technology wizard, so maybe there's some latent, unexplored sibling rivalry, but I don't think it's that complicated. Technology is just not my thing, and I am okay with that. Or at least I was okay with that until I started reporting on primary care, and AI came up pretty much in every conversation. Many physicians who aren't PCPs seem to believe that AI will gradually replace remaining primary care physicians, meaning that the future of primary care will be some combination of AI and advanced practice practitioners. And many PCPs mentioned how much AI scribes were already improving their workflow, allowing them to engage with their patients more meaningfully. And so I got sucked in. And once I did, I was sort of floored by all of it. And what became quickly obvious was that I didn't need to understand how a large language model works. And to be clear, I definitely don't, to think about what AI might mean for all of medicine, and specifically for primary care. And AI, it turns out, interfaces with all of my favorite subjects: trust, cognitive bias, how we teach people to think, and the role of science in understanding a technology that's getting adopted way before we have an ability to understand its impacts. And then I ended up reading an advanced copy of A Giant Leap, a book by Dr. Bob Wachter, who we'll be talking to later this season, that was all about AI in medicine. And as I was reading, mulling over many of the important questions that he raises, I had this sudden realization that for as long as I'm lucky enough to get to write about this profession, I will be thinking about AI. And that possibility weirdly felt really exciting to me. So we will definitely be dipping into AI throughout this season. But for now, back to Dr. Lin. Dr. Lin had mentioned to me that the family medicine doctors in his division were generally happy, and he seemed to think that that was partly because they were implementing AI tools. And so I started out by asking him to tell us specifically how AI was making their lives better.
One particular issue is just the burden of clinical documentation. Writing charts is a really big time suck for not just family medicine, but really all specialties. And there's plenty of studies showing how, for every 1 hour we're actually spending in front of patients, another 2 hours are spent in front of the computer. And a large portion of that is just writing notes, which is important, but we're doing that in our pajama time. Once we get home from work, when we have to work with our children on their homework, we're writing notes and not being present. A lot of doctors are writing notes in the room and not looking at their patients, unable to pay eye contact or be there physically and mentally and be present for your patients. And so that's a really, really big problem that's sort of universal. One of the most well-established tools now that I think many health systems have adopted or are about to adopt is AI scribes. So these are ambient listening devices that are either a smartphone that's taking a recording of the conversation, or a microphone, or some sort of device built into the room, listening in on the conversation that the doctor is having with the patient, and then automatically generating the note, not as a word-for-word transcript, which would be entirely useless, as you know, but as a structured, well-organized, clinically meaningful and useful progress note that is used to both educate patients, interact with other providers, but also for billing purposes. And that has been an incredible improvement on the wellness of our clinicians.
So if you were to offer me a scribe, and I always see emails offering them up, I don't have an outpatient practice. I only practice in the inpatient setting, but I would say no, thank you. And the reason for that is because writing is how I think. And so one concern I always have when we start talking about offloading this task to AI scribes is the act of synthesis. Like, do we know enough about how doctors think, where their judgment comes from, how they pick up on important details to assume that using AI scribes is going to be safe and effective? And if we don't know the answer to that question, is there any way to study it? Or is this just going to be kind of like the EHR, where it just kind of comes down upon us and we realize there are some unintended consequences, but it's not evaluated in the same way we would evaluate like a device or a drug?
I love that question because it is certainly something that can be an unintended consequence. So I think folks are generally aware of that. And now that this is a little bit more widespread and really has moved out of the theoretical realm into daily practice, folks who are interested in, say, continuing medical education, but also the training of our next generation of physicians have raised that as a legitimate concern, right? Writing as a tool for clinical decision making, refining your differential. And so the short answer is we don't really know how this is going to affect all of that. We need more studies that have to be done in order to take a look at the impact potentially on medical education. And there's many professional organizations now that have launched initiatives to really focus on how do we even educate the next generation on the proliferation of these tools? How do you evaluate them critically, use them in practice, and then try to mitigate some of the unintended consequences that we know will happen? So we don't quite exactly know, but we need to find out, and that's really, really important. On the flip side of that conversation, though, are folks who are saying, well, this is not just a documentation tool. Right now it is, but eventually you can loop in other types of clinical decision support functionality to these tools that can help doctors have essentially a live AI assistant with them at all times, which can potentially help them make better decisions in real time. And that the trade-off for that is perhaps the potential for better patient care, making sure that you're not missing any care gaps, before you let the patient leave your room. And so there's advantages and disadvantages of all of this approach. But most people think that the AI scribe is going to evolve very, very soon to include additional functionality that will be helpful for the physician.
And I do think that it's a super interesting issue because everyone in education is having this problem as students write all of their papers with AI, and nobody has any idea what this means for how people learn how to think. And I can't help but watch this happen and think that, like, the way I learn to think is not even going to matter in the future, and thinking itself will just be this totally different thing. I don't know if you've thought about that at all.
Yeah. I mean, you take that to the extreme. You'll hear folks think about that it's not really about knowing a lot of medical knowledge anymore. It's about how to interpret what the AI gives you in the future. And so as AI gets more sophisticated, a lot of the analysis, a lot of the differential diagnosis will become increasingly dependent on AI in one future. And what is the role of the human clinician then? And so it's to wrap analysis in human judgment and compassion tailored to the individual needs of the patient in front of you. That's one answer. But then what does that mean for how do we select med students? How do we train med students and residents? brave new world. Nobody really knows. I am personally of the mindset that there's a core corpus of skills around critical thinking, analysis that we should not give up to artificial intelligence, especially thinking about a lot of the limitations of artificial intelligence, hallucinations of large language models being one of them. In a world where AI can just make up evidence with utmost confidence, and we don't have the right tools to even detect when they make those mistakes, are we ready as a species to give up all of that analytical thinking to the tool? I argue not. But I think theoretically, there may come a day where it gets really, really smart and really, really safe and really, really accurate. So then what then? I think the role of the human clinician will change, and it becomes a little bit more, okay, here's what the AI says it could be going on. Here's what my human instincts tell me. And then these are the things that are right for my patient, and not just a generic human patient. And so there's a lot of new skills that I think we'll have to strengthen. Some skills might atrophy. And then there's a corpus of skills where we might have to say, we're absolutely not going to give up on this because it's too important to what it means to be a physician to give up on. And then, what happens if there's bioterrorism or some sort of event that shuts down our ability and access to these tools? I think that's what we need to worry about too. Like the AI scribe thing, I laugh because every time we have an IT outage where our AI scribes go down for 2 hours, it's literally the end of the world for everybody.
So already people just freak out. They really love their AI scribes.
Yeah.
Okay.
Yeah.
Interesting.
Yeah.
Interesting. No, it's funny because I've paid more attention to AI in media than I have AI in medicine and thinking about what it means to be a writer. But I think I've come to the same point, which is that things that I value, like taste and style, matter for writing. They matter for communicating. And I think they will become even more important in medicine. And we will have to pay more attention to them because that will distinguish those doctors who just entirely rely on AI from those who bring some human element to it, whether that is interpersonal skills or some type of judgment or analysis. And I guess one question I have for you as I listen to you talk about this, I mean, the shift is so totalizing. And again, we are an enterprise that has long prided itself on research and understanding things scientifically before we implement them. What does the research landscape look like for something as big as this that feels like it's happening whether or not we want it to? And I think most people, I don't know what most people want. I think most people wanted to or just understand that it's beyond our control. But how are we going to study this?
Yeah. So, I mean, you raise a really good point, which is that the advancement of these tools is so rapid that it is outpacing research. It's outpacing our ability to educate around how to use these tools. And so it really is a little bit of a scary time, exciting and a little bit scary. A lot of the research that is out there is really heavy in the data science space. So how accurate are these AI tools at making their outputs, at making a prediction, for example? That's there. What's not there is what does that mean in the real world clinical setting when these tools are being adapted in the use of care for human beings? We don't know that. So there's relatively few implementation science focused types of AI work. And there's actually relatively few studies that are prospectively testing these tools across multiple sites. In medicine, we rely on the randomized clinical trial to give us the most gold standard evidence, right? And you want these across multiple sites. You want this to be replicable. Well, there's not a lot of RCTs of AI, and part of it is technical. You can't really do RCTs on tools that are going to function differently depending on the data availability and what the data looks like at different locations. And a lot of these tools, so they're not prospective, and even if they're prospective, they're single site. And so the strength of evidence is low. It's low. And we should all be mindful of that. And there's even some questions like with traditional AI, it's relatively straightforward. We have benchmarks for accuracy. But generative AI, it's a little bit tougher to say how do you evaluate the performance of generative AI. Those tools are basically just next word predictors. And so what are the set of metrics that are relevant for the performance and safety of generative AI? That's an evolving field too.
Yeah. And like, who are going to be the arbiters of that decision? Like, who's going to decide what metrics to use and what outcomes we care about? I mean, there are just so many questions. I should have just done this whole season about AI, but let's get back to primary care. So we talked about the scribes, and it sounds like everybody loves them. Have any of your faculty said no? I don't want this.
Yeah, yeah, there are. And that's perfectly fine. We don't force any
You
of
don't
our
force
folks to
it.
use it. No, absolutely not. I would say we've done a lot of studies and we've published a lot on sort of the physician perspective around these tools. And the vast majority of folks do like them. But there are some who don't want to take them. First of all, they're very efficient in their note writing. They have their own style, using templates and other things. It doesn't really save them that much time. There is an upfront investment that you have to make to sort of figure out how to use the tool and for the tool to adapt to you. So I get it. Sometimes it's just a very straightforward calculation of, do I want to invest in this or not? Or am I doing okay? So for folks who are doing fine before, they're not going to use an AI scribe. But there are other tools that we have made available to our primary care docs that are really helpful. So I mentioned the in basket. So I think that's the other area that's really, really scary. I'll just give you a statistic at Stanford and at many other institutions. The number of patient portal messages that we get relative to number of actual in-person office visits that we see is 8 to 1. So we're doing 8 times the amount of work virtually through the patient portal, through text messaging, than we are through traditional clinic-based office visits. And that's like an entire paradigm shift of how you provide care, right? And so there's a suite of tools now that allows us to better manage that incredible volume of work that we're doing. Things like large language models that can draft responses for the physician to edit before they send back to the patient. So patient sends a message, it analyzes that message, figures out exactly what the patient is asking for, has access to their medical records, drafts a response for the physician to review and edit. And we've shown in studies, we were one of the first ones to publish this study in JAMA, that it reduces the cognitive load of the physicians and improves their burnout scores, for example. Other uses of this are like translating really jargony lab results and radiology reports that the patients can log on to their portal and see, but have no idea what's going on, and translating those reports to layman's terms and accessible language that's tailored to the patient. And that's been really helpful both to the patients as well as to the providers who used to be responsible for making that translation happen. So those types of tools around in-basket management have really helped manage the very, very high burden of asynchronous care that all of us are doing today.
So you said in your JAMA study that what you found is that it reduces cognitive load and burnout. So now I'm just going to harp on the same concept. Like, what does it mean to reduce cognitive load? Do we want that? I guess I have a twofold question. One is, does reducing cognitive load mean we're thinking less? And is there some risk to that we should be considering as we implement these tools? But the secondary question is, we've seen like the creep upon primary care, maybe more than we've seen it anywhere else, where like they have one spare minute and it gets filled with something else. So like, yeah, they have a scribe now, and hey, that, CEO of the health system hears that now they don't have to respond to inbox messages. So pajama time's down, and guess what? They get to see 3 more patients every day. Like, how do we avoid that outcome as we try to relieve them of some of this burden? So sorry, that was a 2-part question. We can talk about the cognitive part first, like what does that actually mean and how does it translate to care? And then the avoidance of the creep.
Yeah. Really good question. So when I say cognitive burden, from the perspective of a lot of clinicians, it's about answering questions that don't really require their level of training to answer. Some of this could probably be handled by a well-trained nurse, but nurses are very expensive resources, for example, in a lot of primary care settings. But we get tons and really like tens of thousands every day of messages around, I got prescribed metformin. What are the side effects? Oh, I am taking vitamin D. Is 2,000 units okay based on my last vitamin D level? Or I heard that there's a new flu shot coming out. Should I take it? Stuff like that are like relatively straightforward. There's generally a yes or a no or a right answer or a recommendation that we can pull from a professional society or something like that, that doesn't really require a physician at the top of their license to answer. And so those are the things that really reduce the cognitive burden of these tens of thousands of messages that we get every single day. There are questions that the AI will not be able to answer, right? And you should say that those questions shouldn't really come in a patient portal, that those should be a visit. And so what we do in those cases is, yeah, that's too complicated. Come in for a visit. We want to make sure we give you the best advice based on you as a human being.
Come in for a visit and we'll see you in 6 months. That's the problem. I mean,
that's another whole hour of primary care shortage and why that is in this country. I'd be happy to come out again and talk to you about that. But your second question is really, really, really important too, which is the availability of these tools. Does it then create a situation where we're being forced to do even more when we're already on the breaking point? And the sad reality is, yes, in some systems, that's what we're seeing. There's a quid pro quo there, like we'll give you this and then you'll have to see an extra patient or something like that. We don't do that in our system. We see this as a really important thing to help our physicians sort of practice modern primary care, which is difficult enough as it is, and that this will help them provide better care and support their wellness. And I'll just say, as I said, I'm the chief of general primary care. In the last 4 years, I've lost 0 physicians to attrition. And so I think that's really important. And the economic argument that we need to make to CEOs is it costs you $1.5 million to recruit a primary care physician, right? Do you really want them to burn out and leave? Is that what you want? Or are you going to invest in this? Let them practice the type of medicine that every single patient deserves in this day and age, and keep your physicians. And so we have to sort of play that economic game as well.
Yeah, I know. I mean, this is what I've been thinking about for over a year at this point. It's a tough one. But yeah, I think we need like a collective professional buy-in that we have to value primary care more, and not just as primary care doctors. People can't see you, but you made the thank you sign.
Well, I'm just so thankful when a non-primary care physician understands and values primary care. So thank you so much for saying that.
Well, no, of course. And you might be mad at me for some of the things I end up saying because I kind of got there. I took a long route to get there, but I've come down on the side of primary care. No, seriously, when I first started this, I was like, should we just let this all die? Like, is that the best way? Because it's so broken. Does it need to just burn down and then start all over, And because it feels like this has been going on for so long, and sometimes humans just need like a big shakeup before they're really willing to implement the change that has to happen to make something better. And I do feel like this sort of incremental approach to helping primary care, unless AI proves to be as transformative as it sounds, this incremental approach, a code here or there, maybe an ACO, like that's not working.
Yeah, you're exactly right. And I'm worried that reckoning is coming because it's just not sustainable the way things are. As excited as I am about the potential of AI, I don't think AI alone is enough to save primary care. That really is a very complex decision that we have to make as a physician community, but also like policymakers will have to really understand where do they want to invest the money for the healthcare in this country. And right now, it's clearly not primary care. We need to change that.
I agree with you. Let's go back to the inbox, because I know this is just sort of the thing that we talk about most when we talk about the bane of primary care's existence, as you so well stated. So I was thinking about like what the last thing I asked of my primary care doctor. I think it was a referral to an ophthalmologist in the inbox. And then I didn't get a response, so I emailed her. I cheat when I don't get what I want. But I was thinking about an AI on the other side of that, and now I'm thinking about patients that I see. But let's say you go to the inbox and you ask for a referral to an ophthalmologist, but it's actually because you're having intermittent blurry vision in one eye because you're having TIAs and because you have occult AFib. And sorry, I can't help but be the cardiologist. How does the AI distinguish between two people asking for the same thing who have very different reasons for it.
Yeah. Well, you can envision in one scenario where you have AI chatbots that are doing fairly in-depth triage. So they're able to have a conversation with the patients through text via the patient portal and ask some of those red flag questions that would lead down one pathway versus another. So to differentiate between a straightforward, yeah, this sounds okay. We'll just go ahead and send you to ophthalmology, for example, versus no, this doesn't sound like this is. There's some red herrings going on. Something is fishy. We need some sort of human level judgment, or we need to ask some more questions to tease out what this is. So that technology today exists. It's not currently built in any form that I'm aware of that is doing that. And I would say that's a fairly risky application that needs to be thought of very, very carefully before we deploy something like that. Basically, having AI as the front door, I think right now it still feels like you need a lot of human supervision for that. Or you can just basically decide this is what I'm okay with AI doing, and everything else I'm going to leave to the human workforce, right? And so at some point, each institution needs to decide where they draw the line in terms of their level of risk that they're willing to accept. AI is really good at repetitive, low risk, administrative burden reduction tasks. And I think it's very reasonable to start there. As soon as you start to let it encroach upon not only clinical decision making, but then also let it be the front door to a patient experience, you have to really thoughtfully ask yourself, is this the right thing to do? And what are the consequences of us missing something? And so every institution has to sort of make that decision.
And how ubiquitous is using AI to answer inbox messages? Is that something that people are doing, or?
It's fairly new, definitely not as widespread as AI scribes are, but it is a functionality that's now available within Epic. And so Epic is fairly ubiquitous. And so these are functionalities that institutions can choose to turn on. And I'll just say today, they're drafting replies, but they're not sending them, right? So you need to review and you need to edit it and you need to send them out. So it's not autonomous. And actually in our study, when we looked at this tool and showed that it reduces cognitive burden and improves burnout scores, we actually didn't see a time savings. And one hypothesis for not seeing a time savings, it's actually a good one. It's that the providers don't fully trust this tool yet. And so they're not just automatically clicking send. They're actually reading the AI response and making modifications before sending it out. So that's actually really reassuring.
Yeah, it is. I mean, I was thinking about this. We spoke with Dr. Bob Wachter the other day, who's, written a book about AI, and it happened that I had read EKGs the other day. I'm the overreader. And so I was thinking a lot about, you see this, like, even you look at your colleagues, that there are people who always change the read and they're so detailed, like you just sometimes I play this game where I see the read and I guess who read it, like based on, because so people approach this very differently, and so, I guess this is no different than the fact that we all have different styles and quality of care that we deliver in the first place, but maintaining the vigilance once you begin to trust a tool is extremely hard. It's a hard thing to ask of humans who really want to save time and get home and not be staring at Epic. And so I'm wondering what the dialogue is like within your AI world about sort of avoiding this automation bias prematurely. By automation bias, I mean trusting too much in the automated response.
We talk a lot about that. We talk a lot about over-reliance and the risk of over-reliance. We know that we're also at risk of training an entire generation of new physicians to over-rely, right? Already, there's a tendency to think about the entire world existing within your one screen of Epic. And my colleague, Abraham Verghese at Stanford, for example, has written a lot about the eye patient, how, patients are now kind of digital avatars based on sort of what the information is on the screen. And the entire world cannot be just what we can see on their Epic screen for the patients. And so we do think a lot about that when we think about the implementation of these types of technologies. And then I will say, though, on the flip side, for the AI evangelists out there, they also make a great point, which is to say, we totally understand the cautiousness and the conservative nature in which you're approaching some of this stuff. But the counter argument is that humans are not that great at practicing safe medicine at baseline, and that we make a lot of mistakes to err as human. And the current state of patient safety with human-driven care is quite abysmal, quite abysmal. And so are there areas where safe and thoughtful implementation of AI can actually help us improve some of that stuff and get us to a different level of care? And I think that there are opportunities for us to use AI in that way. So we just have to be very thoughtful about where we draw the line again. And as the technology evolves, the science needs to evolve as well as we're doing the implementation science work.
Yeah, I mean, I think there will be a media feeding frenzy. As much as the media love talking about medical error, like front page of the New York Times, like this horrible thing happened, and use stories like the first time an AI causes an error, even if that error made by the AI would have more likely happened with human involvement, it's just going to set off such a cascade of fear, and I suspect decreased risk tolerance among institutions. I'm wondering if you guys talk about that, because I'm sure that plays into the psychology of people's decision making around implementing these tools.
We do. And no institution, no C-suite leader wants to make a decision that ends up on the front page of the New York Times. And so I would say, on the whole, institutions are actually pretty conservative on the spectrum of aggressive versus conservative in the deployment of AI. And I think that's generally right. There are some studies that sometimes make us pause, though. So, for example, a lot of the newer studies showing this is really interesting. Is human plus AI or AI alone better at making decisions? And so, for example, making the right diagnosis from a simulated patient case. Human plus AI, or AI alone? And the answer is AI alone.
I know. It's so hard to hear that as a human.
Yeah.
It's so upsetting.
It's paradigm shifting. It's frustrating. It provokes anger and resistance. And of course, medicine is not just diagnosing things. We all know that. But it does make you think. Our worry and resistance about adopting AI, as well-intentioned as they are we actually harming patients if we are inferior to the new tools that we are developing? And so it's very thought-provoking.
Yeah, no, I mean, I was thinking about this in the context of other tough regulatory decisions, like what level of safety, for instance, do you require for a new drug to be approved? And what regulatory bodies are always balancing is like the risk of going too slowly and making therapies unavailable to people who would have benefited versus going too fast and then having unforeseen risks or risks that were foreseen. And I think that AI is in the same boat.
Yeah, absolutely. The other interesting thing is also we haven't had a chance to talk about sort of the patient perspective either.
I was about to ask. I was like, I can't believe I haven't asked this yet.
There's actually not a whole lot of good studies around patient perspective. We are about to publish something around patient perspective of physicians who use AI scribes, which will be really interesting. But there's some studies showing that patients perceive physicians using AI as being less capable, less intelligent, which is really interesting. And then how do you reconcile that with what we just talked about with the AI being better than human plus AI in making diagnoses, for example? There's clearly a trust gap there between physicians and AI and patients and AI that we have yet to bridge. And so as rapidly as the technology is evolving, what we don't really know yet is the cultural mentality from the patient's perspective about their care being influenced by AI. How do you, as a physician, also communicate that, explain that when you yourself aren't trained to do any of those things?
Right. And I mean, trust is really all about emotion. It's not about giving people data. If we've learned anything, right, in the last 5 years, giving them facts is not the way necessarily to build trust. So I think that will have to come from people in society getting used to using AI tools on their own before we ask them to trust us. And personally, like, just thinking even dealing with an AI bot, it's like enraging. Like, even I mean, when they say, like, when I'm like, you sent me that vacuum cleaner and it's already broken, and they're like, I'm sorry, it sounds like you had such a hard day, and you want to just be like, I lose my mind with that stuff. You know what I mean? And so I can't imagine if I were ill and desperate to reach my doctor and I had like some fake empathy thrown at me, although you can correct me, but I've heard that there was a study that demonstrated that AIs are better at empathy than we are. So I don't know if that really means AIs are good at empathy or that we suck at empathy. What do you think?
Oh man, I know that study, highly controversial. I'll say that I think that study's design was a little bit problematic, and perhaps what they were measuring is not really empathy, but the amount of characters that the AI is writing. Like physicians in general, when they're responding to a patient, don't have a lot of time. Their responses are generally short, very, very short, and they're right to the point. That's the way that they can function. The AI has infinite patience, infinite time. They generate a lot of characters to respond to your question. And the large language models are very, very good at knowing what type of language to use to sound empathetic. Now, does that mean the AI is empathetic? Of course not. But it's very good at understanding how to mimic empathy. And so if you compare that to the real life scenario of a human being who is stressed and burned out and overworked and there's no time, responding to your message is not part of their day to day, like there's no protected time for it. They're not reimbursed for it, right? They just need to get it done so they can see their daughters and their families at home, right? That's not a very fair comparison in my mind. So there's no doubt that AI is very, very good at sounding empathetic, but to me, it's not a fair test to put that against the human workforce.
Right. But it is amazing how much empathy we read or lack of empathy we read into text. I mean, if somebody sends you a text and they're just like, thanks or K, or they just emphasize what you said, I'm like, ouch. Like, it's like a dagger. You know what I mean? And like, and I mean, most people I think by now are always reading into other people's text, in terms of like, how does that person feel about me or feel about this situation, or are they annoyed, So it'll be interesting to see how AI sort of shifts that, especially between us and our patients. I want to, for the sake of time, talk about chart summaries. It's another tool I think you're using, right, in primary care. Are you using that within your own practices already, or is that something that's more on the horizon?
It's on the horizon. It's very new. It's highly experimental. The problem is not whether the technology exists. It exists. I mean, today, most email applications have summarization tools, right? YouTube has large language models that can summarize the comments. This is not new technology. The problem is there is no consensus within the medical community what makes a good summary. Every single discipline prefers their presentations in a slightly different way. As a primary care doctor, I will care a lot more about certain things than a cardiologist might or a gastroenterologist might. So for me, I care about sort of what are the interval things that's happened between my last visit and today. Most importantly, hospitalizations and emergency room visits, big changes to their medication regimen, things like that. Very, 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 very broad, everything, right? But if you're a specialist, you will probably want the presentation slightly differently. You will probably want it focused on your lane. Like, it's very, very hard to get consensus on what makes a good summary, and the amount of customization that needs to occur there at the local levels are tough. And then it also starts to feel a little risky if you are getting the summaries wrong in certain situations. And so we are still very much investigating that particular use case, but it is a very relevant one because you know how I cited that study that says 1 hour in front of patients means 2 hours in front of the computer. The only thing that physicians today spend more time doing in front of the computer other than documentation is reviewing the charts.
Reading. So, how do you avoid the garbage in, garbage out problem? I mean, the customization sounds challenging too, but I would never trust. I mean, I know how to read a chart because I've been doing it for a while, and I often feel like it's the most important thing I can offer anyone. But I can't imagine how you train a tool to do what I do when I read the chart, which, by the way, often has to do, again, like the EKG example, of knowing whose notes I trust, of trying to find the first time, for instance, that somebody introduced the word dementia and trying to figure out if it's actually this patient has been diagnosed with dementia or somebody just said that once and now it's being copy forwarded. Like, how do you begin to deal with the laziness that has evolved? Well, it's laziness isn't fair to physicians. People are strapped for time and we rush and we do as much as we can copy pasting, but it's bad. And how do you avoid magnifying that problem?
Yeah. No, I mean you're exactly right. I mean there have been studies showing that like up to 50% of emergency department notes have one or more serious inaccuracies in them, right? It's not a ding at emergency room physicians. They're just in a really tough situation, right? And we all know that the residents and fellows do copy and paste of their charts and stuff like that. So the sad reality is that a lot of the data in our electronic health records today is garbage. And as you just said very eloquently, garbage in, garbage out. So how do we parse that out? It's a hard one. I think we have larger data infrastructure issues that we need to pay attention to, interoperability, accuracy, things like that, that we need to, as an entire data system, figure out. But from a summary standpoint, where I see a lot of the research going is start with the very, very objective stuff that is less prone to, mistakes. So like the structured data fields with labs and radiology, a lot of that is like, yeah, that's the truth. That's the ground truth. We trust that.
True.
We can the echo data is probably right. You might not trust the note, but you trust the report. And so starting with summarization of objective data and then figuring out what parts of the free text, the unstructured text you're willing to put together. And that's really, really tough. I think we're still a ways off.
All right. I want to ask you one more question that's a combined question. What are you most excited about in terms of AI and primary care? And what are you most worried about in terms of AI and primary care?
I'm really worried that, and we talked about this, I alluded to this before, that the pace of this technology has completely outstripped our ability to study it and teach it. I worry about both parts because I'm both a researcher as well as an educationalist. And we've already talked a lot about sort of the research aspect of things, but from an educational perspective, we are basically at this point introducing a whole suite of new AI tools to a workforce that is not ready for it. And then our learners are not necessarily getting education, any sort of structured education. Fewer than 10% of medical schools and residencies have any sort of AI in their curriculum whatsoever.
Wow.
And that's very worrisome because you know how long it takes to get stuff into the curriculum.
Right.
Where do you even fit it in this crowded training environment? And so I'm quite worried about that. And I do feel like here's where our professional organizations need to step up and develop the competencies that are needed and help us think about where to put this in the curriculum. Where I'm most excited is in the low risk applications of AI that will really help unburden physicians from the administrative grind that is crippling them and their practices, leading to burnout, leading them to leave medicine altogether, and leading them to have moral injury because they're not able to practice the type of medicine that they want to practice and that their patients deserve of them. And like I said, I think just within my institution, I've seen remarkable success at preventing attrition of physicians and increasing their wellness with modest AI support to help them with this. And so I'm an optimist. I like to think that physicians today are still noble creatures that want to do the right thing. And we just need to give them a little bit of support so that they can do the right thing. And how do we make sure that we give them the right tools to move towards that type of practice environment that everybody deserves? That I'm excited about.
I'm not that optimistic about primary care, but in this way, I share your optimism. I mean, except the thing I'm most worried about is the two things. One is patients in terms of how they're going to feel about it, especially when it comes to the inbox. I don't want an AI answering my inbox messages. And then the other thing that I'm worried about is the creep, because just given, like, there's no reason that all these CEOs are going to suddenly have like a personality transplant and, stop wanting to like save money on the backs of primary care doctors. Like that, like, why would they change now? And so I really worry about that.
Thanks for worrying about it. I worry about it a lot, and I'm glad that, primary care is not the only folks who worry about primary care. That does bring me a little bit of comfort.
No, I mean, the work you do is so important. And I mean, this is also like a cynical perspective, but, cardiologists, gastroenterologists, they don't want to be doing primary care. And that work isn't going to go away just because we let the workforce disintegrate. And so I think that that's been largely absent from this discussion. And it hasn't been used as much as it could be to motivate other physicians to have some collective movement toward helping primary care.
Yeah. As much as I enjoy what I do and believe in the positive potential of AI used responsibly, I don't think AI will save primary care. That's a much deeper, more complex conversation.
So we'll spend the rest of the season having some of these deeper, more complex conversations. On the next episode, we'll be talking all about the ways primary care has been misunderstood, how these misunderstandings have contributed to its demise, and whether, at some point, it's just too late to save it.
I am usually an optimist, and I remain an optimist. I keep working on things. But you do have to wonder, is there a point at which we no longer have escape velocity, right? Is there a spiraling down that is happening that is no longer correctable? Nobody believed that any banks would close. It wasn't even within our imagination. And then suddenly Bear Stearns one day was gone. Suddenly Lehman one day was gone, and nobody thought that could happen. It can happen, and it would be devastating when it does. And I think about that when I think about primary care and its potential to collapse. What would it mean for us?
I'm Lisa Rosenbaum, and that's next time on Not Otherwise Specified, a podcast from the New England Journal of Medicine. Our editor is Debbie Molina. Our producer is Mary Rose Madden. Adam Strauss is our audio engineer. And I also want to thank all of my colleagues at the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. They've helped me to conceptualize this season and to identify the most pressing and unexplored challenges facing primary care. My new article series on primary care can be found at nejm.org.